Welcome to Sound Beginnings, the Sound Birth Services podcast. I'm your host, Pamela Tessmann, mother of two, an international board-certified lactation consultant, childbirth educator, and former doula and early childhood educator. Based in the beautiful Comox Valley, I've spent 20 years supporting families, and I'm here to share insights, tips, and stories about childbirth and infant feeding. Whether you're expecting your first baby, navigating infant feeding, or you're a perinatal professional adding to your skills and knowledge, this podcast is your trusted resource for expert, evidence-based advice and heartfelt conversations, empowering you with the knowledge and confidence to nurture your growing family. Be sure to follow me on social media at Soundbirths, or connect with me at my website at soundbirths.ca. Let's get started. All right, welcome back to the Sound Beginnings podcast. Today, I'm joined by my friends and colleagues, Dr. James Chen, our local frenectomy provider, and osteopath Sarah Clement, our local bodywork magician. Welcome, you two.
Thank you for having us.
Yeah, thank you.
So today we're talking about oral ties, so tongue ties, lip ties, cheek ties. We're going to talk about what they are, how they can affect breastfeeding, and how to understand when and if treatment is a good option for you. And so before we get started, I think we should just make a disclaimer that everything we talk about here is for informational purposes only and should not be used as medical advice. All right. So, James, I thought we'd start with you. How did you get into this work?
Oh, this will be like 2 hours. I'll shorten it. So, I want to say about 5.5 years ago, my third child was born. He had breastfeeding issues, same with my number one and number two. So my wife, I was thinking, well, same thing again, but this time it was quite bad, maybe a little more than the first two. And one of the lovely local midwives came to our house and took a look at him and said, "You know what, your baby here has a oral restriction, has a tongue tie." And then she looked up at me and said, "Oh, wait a minute, you're a dentist, aren't you? What, you should just do this." And my reply was, "I have no idea what you're talking about, but please elaborate." So she did, and she kind of went over a few things and pointed a few places for me to kind of look into. So I did that. And she also said, "Oh, why don't you just do it on your son as your first one," which is probably the most nerve-wracking things I've ever done as a dentist still. Yeah. So yeah, I thought about it and I watched some YouTube videos, but looking back, that was definitely not an operation. That was just not a good practice. So I wouldn't recommend people just watch YouTube and do it. But basically what I did is I put some topical numbing on my child with my wife and my assistant holding him down. And I took a scalpel and just touch it. And then I barely touch it. I probably make like a 2 millimeter incision. And I'm like, okay, I'm done. I see blood. I'm done. But looking back, it did not do enough. And you're not supposed to use topical local anesthetic. It can cause some serious issues. But anyways, and I thought that was it. And my wife Anna was like, "Oh yeah, I think it feels better." I'm pretty sure it's a placebo effect at the point. Or maybe there is some improvement. I wasn't sure. But keep in mind, it was not a proper release back what I did. But I think she did actually felt some improvement, which made it tolerable, but not great, but tolerable. And I thought that would be the end of my journey of cutting baby's tongue. But of course, word started spreading, and Midwife Lactation Consultant started calling me and asking me to do it. One of them is this one right here, Sarah. So I decided, okay, there's a lot of needs in town. if I don't do it, people have to travel. At the time, people had to travel to North Vancouver. Is that correct? To see a different. So people had to go pretty far to see not a dentist to do this. It's basically like, I want to say quite a few hours on the ferry and quite a few hours on the in the car. So I basically told people that don't send people to me yet, but give me like 3-4 months. Let me take some courses and then we'll get started. And I don't want them to tell other people. I don't want it to be a thing, but it has become a thing. People talk, and I'm really, really grateful that that happened that way, because I now very enjoy what I do on this aspect, and I do go around and give little lectures here and there about it. But that's how I got started and to where I am, I guess.
That's great. And so when you think back to how you did your son's frenectomy, would you have still used a scalpel, or you're using a laser now, right?
That's correct. I have a CO2 laser. It is, in my opinion, a lot more efficient and a lot safer to do. The laser is basically designed for soft tissue incisions, and really, I wouldn't even consider that incisions because it's so conservative yet effective. So basically, you can take the laser and draw hearts on your hand with it, and it's basically just cutting the very outer layer of the skin. Basically, the layer that if you get sunburn, it peels off. That's the layer that it's getting into. But that's all you need to release the tongue. So you don't. So with that, it cauterizes it at the same time too, so I can see better versus a scissor and scalpel. But I do know there are people that are using scissor and scalpels and do get a good result if they know how to do it, if they know the post-op, and if they know their limitations. Because unfortunately, in my opinion, scissor and scalpel cannot release all the tongue tie under the sun properly. They can definitely do a decent amount, but the ones that's really posterior tongue tie where you don't see like an obvious frenum string in the middle, it's like a sheath, those ones are hard to do with a scissor and scalpel, especially with a mobile baby, and obviously you're gonna see a lot of blood. But that's how I feel. But I do understand that dental laser or CO2 laser, like what I have, is not something that you find very often. When I bought mine, I think there was maybe 2 people in the whole BC that has it, and I know there's probably 1 or 2 more now in the province, but I mean that's still quite minimal.
Yeah.
So I mean the brand that I have, that is. So
yeah, that's great. Well, we're really lucky to have you so close by to
thank
us. You. Yeah. I feel like we should probably backtrack a little bit for the listeners so that we can tell them exactly what a tongue tie is and maybe a lip tie. And so would you feel like sharing that? Because I feel like you're the expert in what those look like and how they are released. So
yeah. Okay. So tongue tie, lip tie. So basically under your tongue, there is a frenum that connects the tongue to the floor of the mouth. Not everyone's frenum look the same. Some a lot thicker, some a lot thinner, some very far forward to the tip of the tongue, and some of them are very further back, which we call it a posterior tongue tie. But keep in mind that the visual itself isn't enough to diagnose a tongue tie, lip tie. You gotta go through the symptoms and really have someone to really check in person. Anyway, so let me back up a bit. So if the tie is too short or restricting the tongue's mobility, that's when we consider a tongue tie situation where there's a limitation of the tongue movement, which can cause many issues. And in this aspect, I mean, I guess in our podcast here, focusing on the breastfeeding and the growth and development of the baby. Under the lip, there's also the same thing called a lip tie. That is a little more on the controversial topic, whether it needs to be released or not. And that's another whole lecture that I think we'll get into it if we have time. But to really get, in my opinion, to really get a good diagnosis out of it, if you have a baby that you're concerned about, if you're concerned about them having a tongue tie, lip tie, the first person to go to is actually not me. It's people such as Pamela or any lactation consultant or body worker like Sarah or osteopath, for them to take a look, because there's a lot of times it's not the limiting mobility of the tongue that's causing the problem. A lot of time it's the rest of the body or just the lack of knowledge of how to breastfeed, which is probably most moms most first-time moms, I should say.
Yeah. I often find that people find their way to me when they've tried all the other resources. And then there's something that's still underlying and their intuition is telling them like something's just not quite right. Everybody keeps telling me that it's okay, but I feel like it's not quite right. And as a lactation consultant, I've been trained to look for the symptoms of tongue tie. So I often hear people saying, well, my care provider or the nurse said it was just a minor tongue tie. And so my training has given me the knowledge that it's not about how it looks, it's about how it functions. And then, of course, I'm no expert in the bodywork piece, but I kind of can see when there is some imbalances or a baby that seems really tense. And that's when I recommend that they go see Sarah. And so that's a good segue to get over to you, Sarah. Let's talk about how you got into the world of osteopathy, and maybe you can explain what that is, because a lot of people really don't know what that is.
And crazily, having done it for 15 years now, I'm also really bad at doing it justice in terms of explaining. But osteopathy is bodywork, and it's principles-based bodywork. And I think that's where some of the ambiguity and confusion around, or lack of knowledge around what it is, comes from, is that it's really varied depending on what osteo you see and what you see them for. It will look really different. But essentially, it's really gentle bodywork that aims to try and find the root cause of any symptom picture. In this case, we're talking about body or breast or chest feeding challenges, and tries to support those really gently with a hands-on method. So I found my way to osteopathy actually with the intention and the eventual outcome of working in elite sport with elite athletes, and did that for a long time. So my background is actually in sports science and biomechanics, which I never thought they would come in so handy with this type of work, but I use them every day. And so I moved from Australia just over 10 years ago and had worked a lot in elite sport and moved over here, and I was kind of done with, traveling a lot for sports, and all my evenings, weekends, mornings were all taken up. And so I didn't do that when I came here, and I was like, oh, okay, this is a nice shift, but I'll kind of get back into that at some point. And then I had a lactation consultant start to refer me babies. I was like, oh, I don't know how to take a case history for it. I had tuned out during pediatric class at school because I just had zero interest. And anyway, this lactation consultant was sending me babies. We were getting positive shifts, so they keep sending me babies. And my personality and nature is that if I feel under, resourced or underprepared for something, I'll go out and upskill. So I did. I just went out and took any course I could, in person, online. Anyway, that was nearly 10 years ago, and now has led to me doing exclusively this work nearly, and becoming an IBCLC lactation consultant myself and an OMO functional therapist, and really took a deep dive into a realm that I never thought that I cared about or would enjoy. And now it's my area of passion. I absolutely love it, and I'm happy that it found me.
Mm-hmm. Isn't that funny how things just sort of fall into your lap that way and send you off in a new direction?
Absolutely. Yeah. Super grateful.
Mm-hmm. Yeah, we're grateful to have you too.
Likewise for you.
Very much so.
So let's talk about how important bodywork is in terms of helping a baby get back to functioning before and after they have it released. Sometimes we choose not to, or sometimes we help the family choose not to actually treat the tongue tie because we see so much shift after seeing you, Sarah. So can you walk us through kind of how you treat babies?
And just to echo what both of you have already mentioned is that, so much about oral restriction, and I'm going to use that as a blanket term instead of tongue tie, lip tie, whatever. Oral restriction is, it's not about observation. It's not about palpation. It's so much about function. And for me, when I'm collecting information from families, they come in for an hour and the first 30, sometimes 45 minutes is talking, and it's asking question after question so that I can gain a very broad picture of this experience that this family or the dyad's having. And that before I'm hands-on, before I've assessed, before I've done any work, any intraoral work is, that's where I get most of the information from to, really ascertain does it seem like there's a functional deficit here or not? And then I go ahead and assess both the body and the mouth. And so if we look at the tongue particularly, but also lip, the tongue is a midline structure. And so if we have any tension patterns through the rest of the system, if we consider, muscle, but myofascia, so fascia being like the overlying sheath on muscular tissues, where there's any tension or strain patterns, it's going to, wherever they are locally, like if I pull on my sweater here, you see it move over here. And it's the same through our systems, especially with babies whose nervous systems aren't nearly as differentiated as ours, is that any strain pattern anywhere in the system is going to influence everywhere in the system, including, of course, midline structures, which can influence the tongue being so strong, so powerful, and made up of so many tissues. The first thing I do before I even go near the mouth is have a look at what the rest of the system is doing. Because often what I find is, if there's any, say, preferencing through the neck or through the head, or even through pelvis relative to thorax, wherever it is in the body, once that's gently supported, we often actually see a really different picture in the mouth anyway, both in terms of palpation, but also function, right? And then, so I always start with that. And then I'll do an intraoral assessment. And there, of course, I'm feeling for, tissue tightness, but not just of buccal and lip and tongue restriction, but just in general, and how that relates to the rest of the system, especially through what we call the deep front fascial line. So the fascial tissue through the body is all continuous, and there's different kind of, groups of fascia that are more interconnected. And the fascia that invests the tongue, is continuous right through the toes, the shins, hip flexors, up through, thoracic diaphragm, and then coming into the tongue. So, in a bodywork session, I'm really interested in what's happening through that system relative to the tongue, but also the tongue relative to that system, and how we can gently find ease everywhere to find ease orally, and really focus on decreasing tension. And I might be taking it a little bit too far now, so feel free to cut me off here, Pamela. But I think one of the key things that I used to say recent, but time's flying, the 2018, 2019 Mickey Mills studies, where we started to really understand, a lingual frenem's not just necessarily embryological remnant and tight tissue. It's like a dynamic myofascial structure that when the tongue lifts, we actually...
Yeah, like a global piece. Yeah.
That we get change in that structure as the tongue is moving. So, I think assessment, if we're just looking or we're just feeling, we're missing so much in kind of understanding that tensegrity or that dynamic aspect of what a frenum actually can be relative to everything else in the body.
Yeah. And we see that all the time. You and I, we see a lot of shift happening for babies. I personally really appreciate that the three of us are quite conservative. We don't want to do a frenectomy on a baby if we don't have to. And so, yeah, you're always my go-to if I feel like it's a gray area, I'm like, let's send you to Sarah first.
Yeah, me
James, you're
too.
laughing because you do
Yeah.
the same thing. Yeah.
Yeah, I basically said if it's because there are going to be cases where I take a look and excuse me, when I palpate it, I'm like, I'm not 100%. I think there's a tongue tie here, but it feels like there's a lot more than just the tongue tie because just a lot of tension overall. In those cases, a lot of times, and especially the patients are from locally, not traveling 3-4 hours to see me, a lot of time I'll say, hey, why don't we hold our horses here and for you to see Sarah a few times and see how it goes. Because if the tension releases itself from the body work, then I don't have to do anything. And trust me, it's not. it doing this doesn't, for some reason, just doesn't get easy. Like every time after I do this procedure, I have to like do a little walk around the office to kind of calm myself down because it's just not fun.
Yeah.
Holding doing this. But so yeah, that's. By the way, I was listening to Sarah. I'm like, Pamela, you need to have Sarah on for like 2 whole sessions because there's just so much
You
stuff
too,
that she can
James.
tell you. There's just the tongue. There's not much more for me. So.
No, I know. We could go on forever, I'm sure.
All of us.
Yeah.
Could, for sure.
Yeah. I do want to speak to the importance of prep before a frenectomy though too, because I think that it's really easy for families to really hope for that quick fix, especially when they've been struggling so hard and they've finally found the answer to why. But we know that it can actually make things worse if we rush into it. And so, Sarah, can you speak to that a little bit about what that might look like?
Yeah, for sure. And I think kind of just, as a continuation on from what I was saying in terms of that, what I refer to as tensegrity, so tension and integrity, that, everything being so interconnected is that if there are strain patterns and there's tension through the rest of the system and we just release that one aspect, we're not necessarily addressing everything that's implicated in the functional deficit. And that's why I always come back to it. It's like, what is driving this functional deficit? Is it this frenum? And sometimes it is. And the unicorn babies that have the release and it's like, okay, this is night and day. But as we all know, for the most part, that is not the case. And so I think from a nervous system point of view, a baby that's not well regulated neurally, which is hard, right? Because often babes who have oral restriction or, having trouble feeding, there's, they might be gassy, they've got holding tension in their system. So it's like, it's really tricky because sometimes once they have the release, they are a calmer, we can calmer and well regulated, of course, different things. But I think a baby just in general who's well regulated, has less tension in their body, is going to have a better response, but also is going to be more able to understand with their very limited, neural maturity, what to do with their new tongue. Like if we consider a tongue that can elevate this far and then all of a sudden can do this, there's no mapping then from here to here. And so a baby who has tension and isn't well integrated through the rest of their system is going to have a much tougher time figuring out what to do with that than a baby who's, integrating well, functioning well from a structural point of view. It's just going to make it much easier for the dyad to get that shift to better function, which again, always the key, right?
More coordination, more strength,
Absolutely.
More mobility. All of those pieces need to come together and make those neural pathways and connections and habits essentially, right? So we want to move babies kind of a little bit more away from those compensations that they might be having so that when the tongue is released by James, that they can actually, move properly and start releasing all that body tension too. So, yeah.
And I think as a secondary to that, and, talking about doing body work, and also you're both very kind in saying, sending people to me, but I recognize that there are lots of wonderful body workers in our community and elsewhere.
Yeah,
and so just body work in general, I'm all big on, so big on babysitting whoever they can in any community, anyone who has a pediatric focus and passion is amazing. And I truly believe it doesn't matter what their modality is, whether it's physio, chiro, osteo, cranio, it doesn't matter. If they're pediatrically passionate and skilled, great. So just to say that piece, but also where was I going with that? Oh, so the body work in session is really helpful, but one of the big things that I try and do is send folks home with as much as they can to gently work on, partly because, I'm an out-of-pocket service and I'm really cognizant of that, but also because, small frequent exposures are going to make so much more sense for an infant's nervous system than, a big session. More spaced out. So that's the other thing, is I think doing the pre-work is a really nice way to start to introduce families to doing some work, so that yes, they can help prepare, but also they can get used to doing the aftercare and understand their infant's mouth and kind of get a baseline and a reference, and just feel more comfortable being intraoral when, especially post-release, things can be a little bit more, of course, sensitive and uncomfortable, and harder for families to get in there because the response can be pretty intense. So I also like that aspect of as the pre-work, is just getting families going with that.
Yeah, I agree. Yeah. Gets everybody used to it. And so James, what do you have families doing now in terms of aftercare?
Well, first of all, I tell them that they need to see someone who knows bodywork within a week, ideally. So my post-op is, number one is stretches. So I would call it exercises. So what it is to put your finger in the baby's mouth and just do some like lateral or vertical kind of rubs to make sure the wound doesn't heal back to its original state. The tongue or the lip will want to go back to its starting point when I release them, and you just kind of want to remind the tongue and the lip not to go back to that area by kind of disturbing it, to force it to heal a different direction. This is not a fun procedure to do for parents or the baby for the first few days, but it does get a lot easier and better. Some parents, they will do everything that I ask for. This is extremely rare, but there are cases where they do everything I asked for, and for some reason there's still some reattachment to or even back to the original point, so I have to go do the second time. But most of them not, and especially if the babies are under a care of a body worker, so they can get rid of all the kinks and all the tension, so that things doesn't want to just tighten back together. On top of that, I do recommend some baby Tylenol to go along with it, because, like I said, it's not a comfortable procedure or comfortable thing for the baby to go through for the first few days. But usually I think, and correct me if I'm wrong from you guys' point of view, because I usually just send them right back to you guys for the follow-up. But I think most parents said 3 days or 3 to 5 days later, it becomes a lot easier, because everybody's kind of getting used to it. But that's what I've been told. I don't really know if that's the truth, to be honest.
I think it is. Yeah. Yeah, because I see babies pretty quickly after they see you, within about 3 to 5 days. And usually that sort of acute stage is over by the time I see them. So yeah, they're much more comfortable. I did find that with your other laser that you were using a few years ago, that did cause a lot more pain for the babies for a lot longer. So this CO2 laser is awesome.
No, thanks. Yeah. I still have the old one, just in case this one goes technology things happens as a backup. But I don't know. I haven't touched the old one in 2 years now. I'm not sure if I know how to turn it on.
Might just blow up the place.
You never know. You never know.
Yeah. Well, let's look at the questions from Instagram. So we have one person asking, is a lip tie fine if they have no issues with feeding and are gaining weight fine?
That's a hard question to answer, to be honest, because there's a lot of factors involved with it. But most of the time, unless there's some surprises, I would say so. You can leave it alone. But there are some rare cases where the lip tie is just so tight that's causing restrictions in the body function, which Sarah can probably jump into. Or if it's a very severe tie, it will cause the bone not to be able to grow around the area properly. You're under the gum, so it becomes like there's a minor divot or ditch which prevent the front teeth from closing properly down the road, or pain from toothbrushing or collect food around the lip tie, which leads to early childhood decay. There is a paper recently. Oh, actually, no, forget that. That's a different thing I'm thinking about. But anyways, it is a pretty controversial topic, to be honest. It used to be I tell people this 3 years ago. If you come to me, if I see some sort of restriction in the lip and the tongue, I will tell you probably need both done. But these days, the understanding of the lip has kind of changed. A lot of people said that you don't really need to release that for breastfeeding or for a lot of functions, like what I used to believe. So I'm a lot more conservative about that approach of doing the lip tie. And if it's kind of on the fence, like if I lift it, there's a few things I do to check if there's any sort of restriction. But if there's mild to moderate kind of restriction, I usually have a chat with the parents and say, this is what I see. I think you'll be fine leaving it, but there's a small chance I can cause this or that. Do you just want me to deal with it now, or do you want to leave it alone? I don't personally, in those situations, I tell them I personally don't have any preference, because I think either way is fine. If you want a peace of mind, if you want to avoid other issues down the road, which may or may not happen, by the way, that's why my recommendation is not to do it for sure. Then if you just want me to do it, yes, I can. I will do it. But I do want parents to know that it's not an absolute necessary thing to do. So they need to be very clear about that, and they need to fully understand that. Some people come in with a lot of online research done already, and their mind's kind of made up, and that's fine as long as you believe in it. Some people are not sure, and then if they're not sure, I usually just tell them, hey, if you're unsure, let's just not do it, because I don't want to do something permanent when you're unsure. Yeah, I want you to be sure before I can proceed. Because sometimes I can just do, if there's a tongue tie, I can just do the tongue and then see how things go. If it goes well, and the lip tie is not major, then I think we're fine. But if you don't really have any obvious functional issues or symptoms, then I really don't see the major need to do the procedure. But I'm just looking at a dental point of view. I'm sure Sarah can probably jump in and talk about.
Yeah. What's your take on that, Sarah?
I think, so completely, I guess, not considering the dental point of view. So function over everything, right? Like if functionally everything's fine, then probably, I think leaving it. One thing I see a lot is where there's midline restriction, there's also generally a lot of lateral restrictions. We talk about buccal ties, can of worms, like everything else in this realm. Whatever it is, that lateral tightness, those lateral bands of tissues, they respond really, really well to bodywork, in session and also taken home. So, if we think like, pushing being able to evert or get the lip up and out of the way is really important. And of course the midline is going to be really important for that. But if it's really tight laterally, then even if we release midline, it still might be really hard for that lip to evert. So one of the big things I like to focus on where there is potential lip tie, and I say that obviously because lip restriction is just making sure the whole lip has good mobility relative to that midline, and sometimes that makes a huge difference in itself. And then also considering like the orbicularis oris muscle running all the way around in the circular fashion. If we have tightness anywhere there, we're going to have tightness of all of that. So another thing I'll really get families with lip midline tightness to work on is just getting less tension through that orbicularis oris and even mentalis, and just making sure the lips in general can move better. And I find that can make a huge difference relative to a lip tie, even if that frenum kind of doesn't change at all, which it doesn't really, right? From a functional perspective. And I think a lot of that is, changing the relationship with the cheeks and giving the cheeks more mechanical advantage. So I think there's that. And then the other thing I would say is, yeah, the lips form an important secondary seal, but if the tongue as a primary seal is doing a really good job with its, cupping and spreading and elevating, extending and doing all those things well, that, we want to promote a great deep latch and all those things. And arguably, if we don't have lips everted, then the latch depth and quality is, of course, affected. And I'm, all for promoting the best latch we possibly can. But I think also a well-functioning tongue is going to be really important and probably can, I don't like to say compensate because that starts to have negative connotations, but possibly, if there is a little bit of lip restriction but a greatly functioning tongue, okay, there's still probably the functional outcome is still probably really good, which ultimately is good function, right?
Yeah.
So that's kind of how I look at it.
Yeah. That's the goal, is to just, for the functioning to happen.
So one thing that I think is really important to acknowledge here is, there's really poor evidence base in this whole realm. It's such a can of worms as an area in general. And, so obviously working with infants and their families, getting ethical consent or ethical approval and designing studies that are actually going to give us any decent information is really challenging. And so because of that, we don't have great research. And so something I grapple with every single day in supporting families when they're asking questions and when I'm providing information is really being clear that, I will give you the best information I can with the limited research we have, but that it is really limited. And, so being conservative as we all are, I think has an extra importance because we don't necessarily have a great body of good quality literature to back us up,
so true.
in terms of providing information.
It's so true. Yeah. And I think you and I have spoken a lot about how we've heard of these other sorts of ways of helping families, but there's not evidence for it. So we don't want to touch it. We don't want to go there because, we want to protect families, but also ourselves. And it's so hard when they come to us and they're like, just tell me what to do. I just need you to tell me what to do. And I'm like, I can't. This has to be your decision. So it's tricky for sure.
So on that note, I do have, now thinking back when Sarah was talking about it, I'm thinking back, there were a few patients over the last few months that, or babies came in, the mom just was, the only thing they want me to do is just the lip. And when I check the mouth, the tongue looks okay too, the lip, borderline. And they were convinced that it needed to be done. And obviously I go over my spiel about, it may not need to be done. We don't need to jump into it if you don't want to, because it might be fine. But these few parents were pretty convinced from either what they read or what they've been told. So I went ahead and did them and then follow up with them. And they saw a big improvement, which I have to say it's a bit of a surprise to me. So obviously this is still an area that I can say I can fully tell if this one will work versus this one won't, just because there's just so much stuff going on. And I also don't know how much of that is like a placebo effect. So, but just want to point out there are times where doing that lip well, they can help the situation. It's just not as common as the lip.
How do you think buckle ties tie into that?
I don't do buckle ties a lot. In fact, probably one every few months, if even that. Buckle ties, the reason I didn't do them a lot is because there weren't a lot of research about it. In fact, there weren't any research about it that's convincing enough. I believe last year, there was a paper that came out regarding it and gave a classification that was put together by Dr. Richard Baxter, who is a pediatric dentist in Alabama who does a lot of tongue tie, and he has this whole course about tongue tie thing for dentists like me or or lactation consultant and all that. So it wasn't until then there was a proper research about it. I am still a bit hesitant about doing them. There are times that I do the midline, the regular lip tie, the midline one, and I go back and palpate the buccal tie, which is the side of your cheek, under the side of your cheek, and I can no longer feel it anymore. So it's kind of odd, and I don't really have any good answer about that. I obviously probably just because now it's more relaxed and then it's hard. You got to push a lot harder to kind of feel that, and then if that's the case, I don't really think it's needed to be done. But yeah, that's a tricky one. If I see those, if it's severe, not meaning that if it's kind of like straight up to the tip of the gum where the teeth are, and really prevent the cheek motion, then yeah, I'm happy to do that. But for me to do those procedures, I want it to be very obvious because number one, it's not something that's very clear in the world of research, and number two, it's if we don't have to do them, that's great because that's two extra kind of injury spots. So
Yeah.
yeah, I don't know how too much about buckle ties is kind of what I'm getting at. I mean, there's not a whole lot out there to back up one way or the other. So it's kind of like trial and error, and again, lots of explaining to the parents, and if they want me to go ahead, or if they already done enough research that they want me to do it, then yeah, I'm happy to. I'm happy to do a lot of things as long as the parents are willing. That's kind of my point.
Yeah, I think that's great. I think people really appreciate that information to make that informed decision, right? That's the goal that we're going for with all of this is, taking their feeding goals into consideration, taking their whole nervous system of the whole family into consideration. Like, how ready are you for this procedure? And do you have the support at home? And do you have enough information that this decision is feeling really good to you? Because like you said, James, we don't really want them to do something that's unnecessary or that they're going to have regrets over.
That's right.
So the next question is, what did people do before cutting and lasering was an option for tongue ties, I'm assuming. And did we all suffer with oral dysfunction? So, yeah, who wants to answer that one?
I'll start a little bit from what I know. I do get that a lot. What did people do before? I think from the many lectures, podcasts, and things that I come across, breastfeeding has become more of a thing that people do because the benefits. And I'll let you guys talk about that because that is not something I'm an expert of. But because of that, more people are breastfeeding or trying to breastfeed. So obviously, because of that, many moms are starting to notice, oh, seems to be an issue. Versus before, people, I think, correct me if I'm wrong, I believe people weren't really trying that hard to breastfeed. A lot of times, people have issues; they just go straight to a pumping or even just formula, and you know what, they survived just fine and they grew just fine doing those things, and which that's great. And obviously if that's the case, tongue tie, lip tie never really get noticed because we kind of bypass the first symptoms by using a bottle. But because now people want to breastfeed, and with all the benefits that breastfeeding can provide, people are more willing to do any sort of intervention to try to continue breastfeeding for a few months. So people didn't really suffer. Some people probably did. But but people found a way around it. But now, I think now the trend is trying not to go around it and trying to do the best. And you know what? With that said, there's still parents out there that just can't spend the time, doesn't have the money, or for whatever reason they can do it, and they have to circumvent this issue by bottle feeding. I don't think there's anything wrong with that. Breastfeeding probably is just not for everybody, unfortunately. But I will let you guys talk about that instead of me.
Yeah. Yeah. Well, I mean, I think there's still a lot of compensation that can happen. Like in my own journeys with my two boys, you guys both know my first, we didn't actually deal with his tongue tie until he was 12. And he was having all sorts of other issues that we could have a whole other podcast on. But with my second, we found it at 7 months, and this was 11 years ago. And so we treated him at 11 months. But for me, my breasts were the kind of breasts that were really responsive. So I had a good milk supply. They didn't take a lot of work to produce milk and release the milk to my babies. So my body was passively feeding my babies. But there was always sort of like this underlying like, oh, this kind of doesn't feel that great. It's not super painful, but it doesn't feel great. And my baby is super gassy and vomiting all the time, like powerful vomits, and not comfortable. My youngest was really, really colicky, he just screamed for the first 3 months of his life. But because he was gaining really well, he was gaining so well, actually. He was gaining a pound a week for the first 8 weeks of his life. So he was born 10.5 pounds, and he weighed 18 pounds by the time he was 8 weeks old.
Oh my goodness. That's incredible.
Yeah, but he had a tongue tie and he was a miserable baby. So like there's all sorts of other reasons to be, like you said, James, intervening to make breastfeeding a little bit easier. It's not just for the baby, but it's for the parents too. Because it's a dyad. We're not working with one or the other. One affects the other. So if the mom's uncomfortable, she's not going to enjoy breastfeeding. It's not going to last very long. We're not going to have a really long relationship with feeding. So yeah, I think there's definitely compensations that can happen with babies. They learn to feed, and depending on their parents' body, maybe that baby is being passively fed by really responsive breasts. And in the other spectrum of that, we see major problems with no milk supply because the baby is not able to draw the milk out of the breast very effectively. We see really uncomfortable babies. There's a wide spectrum of symptoms that we see now because we know more about it. Mm-hmm. Mm-hmm. And I think, isn't there an old wives' tale that midwives way back when knew about it and they had a sharp pinky nail?
Yeah, I was actually going to mention that. In my lecture to UBC Dentistry, I had a slide about the history of tongue tie, and I hate to say this, I don't remember exactly what it says on the slide, even though I made it. But there is a museum out there somewhere in New York, I think, that has pictures and tools of what people used to use in the 17th century, so 1600. Very similar to what I used, other than the laser part, but it's quite similar. Yes, midwife, apparently back in the days, midwife and surgeons have this kind of rivalry of who can get to the baby and release the tongue first. Like, so midwife, they will have sharp nails to accidentally cut it, or because they are not allowed to use a scissors and scalpel in the baby's mouth while the surgeons can. So I think there is a bit of a rivalry of who should do it. So it was being done, but I am pretty certain that even back in the days, similar to now, it is not a well-known situation. Most likely not every midwives out there are doing it. My guess, if I had to guess, probably most people are not, but a small group of more progressive group are doing them. That's my that's my take on that. But yeah, it is definitely a thing back in, you can go back at least 400 years or so.
Mm-hmm. And those were for the really obvious tongue ties. Those, I would think they would be the ones that are coming right to the tip of the tongue, the anterior ties.
Yeah, the one that
The more
tongue's
obvious.
just not moving at all.
Mm-hmm. Yeah. And I wanted to loop back to how the culture of breastfeeding is shifting. Like you mentioned, it's very true that our culture was very bottle focused. There was less restrictions around the marketing of formula. And so formula became this thing that was really kind of like cool to do. And it was generally okay. And they were touting formula as something that is equal or better than breast milk. And I could go so far into that, but a lot of damage was done with that, especially in, lower resourced countries where they didn't have clean water, and lots of babies were perishing because of this when they could have just been breastfeeding. And so I think it's great that there's more restrictions around those types of marketing of formula, and we're starting to shift more back into how breastfeeding is a lot healthier.
Mm-hmm. And then also, recognizing that fed is best and that there's nothing wrong with bottle feeding for the families that are relying on it, either to supplement their feeding or, to exclusively. Because I think and I can speak to this personally with my first, who was probably orally restricted, hard to say, long story there, but I used to say successfully, I now say conventionally breastfed, and by 4 months she wasn't feeding from my body at all. And I found that really challenging. I felt judged. I felt a lot of things around that, but I would have people overtly comment on the fact that I was feeding my baby a bottle. And so I think, it's wonderful. Of course, breastfeeding is so advantageous and breast milk is so advantageous. But I think there's also, I love families to know when I'm supporting them for feeding, that I'm supporting them for feeding. I don't care how it looks. I just want them to feel good about how it looks and how it functions. And it doesn't matter what it is. If they feel good, we're there.
Yeah, I think that's really important, just in terms of helping the parents just feel really good with their parenting and their choices, and being able to move forward with confidence, because there's already so much judgment with parenting and feeding your baby that we just, we need to support them where they're at, for sure. Yeah, sorry that happened to you. That's no fun.
Yeah, it's all good. It was a really, I think, important learning experience, given what I do professionally, right? It's like my empathy is through the roof for families because of it, and it's all good. But thank you.
Yeah. I definitely had some comments too when I was breastfeeding my oldest. I had people ask me, "Well, how long are you going to do this for? It's been 6 months."
Right.
You're done now, right?
Right.
Yeah.
There's a lot
as I
of
feed my 18-month-old now.
And for reasons, I wasn't able to breastfeed for much longer after that. And I think in hindsight, it was because of his tongue tie. And so same, I started using a bottle as well. But I think because he was an older baby, I didn't get judged. That was just sort of the normal at that time. But then I was able to breastfeed my second until almost his second birthday, which is pretty fabulous.
I think my wife feed all three of my kids around until maybe 9 to 11 months. I think the few things. Number one, my kids are pretty close in age. I think the second she got pregnant, it's kind of like, you guys probably know better than me, but that's when it stopped. Or when the teeth comes in and some chewing started happening, I was like, okay, no, you're done.
Yeah.
So, and that's fine. It's funny you guys mentioned that. I thought of a classmate of mine who recently had a baby, and I overheard this from another classmate that she just was sure that breastfeeding is not her thing. So I don't think she ever tried, just bottles only, and
Fair.
doesn't care about how other people think about that. That's just how she wants to do it. And you know what? Looking at it, I'm like, nothing wrong with that. Nothing wrong with that if you decide this is what you want to do. I never really talked to her about it. I overheard this through a friend, but I just thought it was interesting. Whether or not you want to include this in your podcast, you can decide later. But I just thought it's an interesting thing because she's like one of the smartest girl in the class. I'm just like, nope, not for me. Not even gonna try.
Well, and there's a lot of reasons that people will choose that, and that could be that they have some trauma, and that could be sexual trauma, and they don't want their breasts being touched that way. And it could also be an oversensory thing for neurodivergent families. And so there's a lot to navigate with families when we're looking at what their goals are for breastfeeding or body feeding or bottle feeding or both. And yeah, same as you, Sarah, I like to think of myself as just sort of being the facilitator of like, here's how we can do that. This is your goal. Let's think about ways that we can incorporate that into your life. That feels really good. Okay. Well, I think what might be helpful before we go is to let folks know how they can get in touch with each of us and what the best route is if they're having some feeding troubles.
Sure. Well, I'm a dentist, Courtney, in Vancouver Island. The office is called Downstream Dental, so can always Google that and then get a hold of me. If you are interested, I would, just like I said in the podcast earlier, I wouldn't recommend coming to me directly without seeing anybody else. It's very important to see people that knows about breastfeeding. Obviously, unless it's maybe like 5-year-old that you're wondering about tongue tie, lip tie, and I'm happy to take a look. But if it's a baby that has breastfeeding issues, that you're suspecting tongue tie, lip tie, I should not be your first line of a solution, I guess. Body worker or a lactation consultant should be the first group of people that people see, so that they can rule out other issues or get you prepared for the procedure coming to see me. So I have a lot of parents that comes to me and said, oh, I read about you on Facebook, or my friend had this done by you and said that I have most likely have the same thing. I usually said, and you know what, rude, but you should probably see someone else first before coming to see me. If for some reason they have a reason to bypass that, I mean, I'm happy to chat and then kind of go from there. But that's what I would recommend anyways.
Great. Yeah. And how about you, Sarah?
So for bodywork and functional assessments for oral restriction or suspected oral restriction, my business is Growing Bodies Wellness. And so if you Google that, that should come up. I'm based in the Comox Valley as well on Vancouver Island. And my website is viosteopathy.ca. And email is the best way to reach out with questions. There's online booking on my website, but I recognize that working with infants is very time sensitive. So I really try and see infants within a week of families reaching out to me. So emailing me, Sarah with an H at viosteopathy.ca is the best way to get to me, especially for time sensitive cases.
Perfect. Same with me. I like to get folks in as soon as I hear from them. I don't like making them wait. So reach out to me. I have online booking as well at soundbirths.ca, or you can email me at info@soundbirths.ca. Thank you both so much for joining me tonight.
And thank you, Pamela. Thanks, James.
Yeah,
Thank you.
good to see you, and we'll talk to you soon.
Sounds good.
Great.
Thank you.
Thank you.